Good evening, everybody. Coming to you from DeBakey Heart and Vascular Center. This is Dr. Randall Wolf. I'm one of the members of the DeBakey Heart and Vascular Center. And this evening, we are going to discuss a very important topic in the area of atrial fibrillation, and that's called the left atrial appendage. As a physician who treats people with atrial fibrillation, one of the most common questions I am asked is, what is the left atrial appendage? Why is it there? Why is it important in atrial fibrillation? And we are going to answer those questions for you this evening. If you have questions, we will take your questions in two different ways. We'll put this on the screen now. You can join this conversation on the web. You go to POLLEV, that's pollev.com, enter DeBakey, and respond to activity. Or if you'd simply like to text, you text DeBakey, DEBAKEY, to 37607, and then text in your message. And we're talking about the left atrial appendage, also called the LAA, and we're talking about atrial fibrillation. So if you or a loved one has AFib, you're on a blood thinner. The reason you're on the blood thinner is to create blood clots in the left atrial appendage. We'll talk about that. We'll talk a little bit about the anatomy. We'll talk about the treatment. And just to give you a little teaser, there are no less than 12 different devices that are either available or they're in development to close the left atrial appendage. So there's a lot of questions about what is this black hole of the left atrial appendage. And to better understand it, I thought we should start at the beginning, and that is start with what most surgeons start with, which is, what is the anatomy? In order to understand the physiology, understand the pathology, the treatment, it's best to first start with the anatomy. And there's nobody in the world that knows this anatomy better than Dr. Miranda. Dr. Efrain Miranda has been kind enough to join us in this meeting on left atrial appendage and atrial fibrillation this evening. He is a clinical anatomist. He consults for companies all over the world, specifically medical companies who are researching treatment of the left atrial appendage. This is a very hot topic, not just among patients and people who sell blood thinners, but also among at least a dozen companies who are coming up with different ways to close this device in order that you might be able to get off a blood thinner. So from Cincinnati, Ohio, Dr. Efrain Miranda. Dr. Miranda, welcome to our program. And if you would give us a short introduction and then talk to, in lay terms, for the most part, the people who might be watching this program who've been scratching their heads for years saying, what is the left atrial appendage? Where is it? Where does it come from? Could you answer those questions for them?
All right, thank you very much. Thanks for the invitation. And yeah, I mean, the main problem with the left atrial appendage is that it is mostly an unknown structure for many people. It's an embryological remnant. It's there because it was there initially, and it's kind of a leftover. It has some functions. I know you will talk about that. But what I would like to do is share with you a very short PowerPoint presentation and go through some basic stuff. And I'll try not to use any big words. How about that?
That sounds good. And when you talk about something left over, would that be somewhat similar to the appendix?
Yeah. The appendix, or it should be called a vermiform appendix, which dangles from the cecum in the colon, is a structure that is just an embryological remnant. It is there, but it doesn't do a lot. It has some functions, but we can live without it. The same is true for the left atrial appendage. It has some functions, and you'll touch upon them, but a patient can live without it with no problem.
When I look back, Frayne, at some of the older surgical literature, it's not referred to the left atrial appendage, it's referred to the left atrial appendix.
Yes, because the Latin word should be appendix, which means appendage. That's why for example, the appendix and the colon, its proper name is appendix vermiformis.
Which means worm-like, right?
Yep. And this left atrial appendage, its proper name is actually left auricular appendix, because it looks like a little ear. Exactly. Okay. But over time, it's people call it the atrial appendage, and I guess that has stuck, but its original name was little ear.
And would you clear one other thing up for our listeners?
Sure.
Again, we're talking about, for those who just joined us, we're talking about why is the left atrial appendage so important in atrial fibrillation? And it is, well, that's where blood clots form. We'll get to that. And I've got Dr. Miranda with us, who is a clinical anatomist. And if you would like to join us, you have a question about your AFib, about blood thinners, you can text it to DeBakey, DeBakey, to 37607. Text DeBakey to 37607, put in a question, or you can also use website polev.com and DeBakey. Now, Frayne, in fact, there are two atrial appendages. There's not just the left. So maybe we should start there.
Well, there are two, right and left, and their anatomy, as we'll see, is quite different. And while one is almost triangular, white base, where blood can go in and out with no problem, the other one is tubular, with lobes, constricted, where blood can get stagnant, especially if there's not good heart function, and that's a left atrial appendage. Let me start the PowerPoint presentation.
Yeah.
And we can tell me when you see it.
Yep, looks good. Left atrium and left atrial appendage.
Okay. Well, these are the two different things that people need to understand. First, in the heart, there's a right and a left atrium. And the atrium, the word atrium means entrance, and it's literally the entrance to the ventricular portion of the heart. But within the left atrium, there's a little outcropping, if you will, which is the left atrial appendage. Basically, the embryology is very, it's a little bit complicated, but the heart starts as can you see the cursor? Start at 23 days, almost like a tube. This tube starts to fold, and we'll not go into the detail of the folding, but eventually you'll have here in blue what's called a right atrium and a left atrium. Well, that's the original left atrium. In the next one, you see a primitive ventricle, and you see a primary atrium. But this primary atrium will eventually be moved to the side and become the atrial appendage. And the veins will dilate and become the actual atrium. The thing is, and here I just added something, the right atrium starts to develop as the right atrial appendage starts to develop as a structure that, as you can see, has a wide base, a wide opening. So blood can go in and out very easily, even with atrial fibrillation. It's not as terrible, but look at this. The left atrial appendage is almost like its finger, like a chicken wing coming out of the atrium as a narrow tunnel, and then has these lobules, these outcroppings. So blood, which gets in it's not easy for it to get out, and so it can congeal. Would you like to comment on that?
Well, yes, and that's clinically what has been reported is that blood, if it slows down enough, doesn't matter whether you're a rabbit or a human, if it slows down too much, it will clot inside the vascular system. And the left atrial appendage is one of those cul-de-sacs. Cul-de-sac means dead end, where the flow of blood may slow down enough that it will clot. And unfortunately, when the heart is in atrial fibrillation, the blood slows down even more anyway. So the left atrial appendage is not squeezing the blood out, it's simply shaking, because in atrial fibrillation, as you know, the two atria are not beating, they're simply shaking. So the blood can slow down dramatically, and the place in the heart that the blood slows down the most is the left atrial appendage. It has been said that 97% of blood clots in the heart in AFib are from the left atrial appendage, and it is postulated that those blood clots can break off, and when they break off, they go into the left ventricle, out the aorta, and unfortunately, the first major arteries off the aorta are the arteries that go to the brain, and that leads to stroke. So you could say that atrial fibrillation is not just a heart disease, it's a brain disease too, because the most dreaded complication is a stroke, and probably that blood clot came from the left atrial appendage when the two upper chambers of the heart were not beating when the heart's in atrial fibrillation. So right now, clinically, if a patient is in atrial fibrillation and it's contemplated to do a shock to the heart to get the heart back in rhythm, the first thing that has to be done is an echocardiogram to determine whether there's any blood clot in that left atrial appendage already. And if there is, then a cardioversion can't be done, because getting that heart back in rhythm could knock that blood clot out, go to the brain, cause a stroke. And secondly, about 15% of people who present with new onset AFib present with a stroke. They don't know they have AFib until they've had a stroke, and it comes from left atrial appendage. So it's incredibly important part of the treatment of atrial fibrillation.
I'm going to show the audience a couple of clots formed exactly because of this. As patients look for information, they will find themselves with words they might not understand. One of them is sinus venarum. It just means the smooth portion of the atrium. The word ostium means opening, actually means mouth. The plural form is ostia, and we'll use it. And this is kind of interesting, trabeculated versus pectinated, and I'll explain that. Trabeculated means like a mesh. Pectinated means like a comb. And let me show you this. If you look right here, let me annotate.
First, tell everybody what you got there.
Oh, well, okay, this is a heart. And what we have here, let me get the pen. And what we have here is the right atrium that has been open. And inside, you can see this smooth muscle, almost like the tines of a comb. And that is pectinated, and specifically, that's the opening of the right ventricle, which you can see is extremely wide. So even if blood got in there, in between these corrugations, these pectinations, it really won't affect a lot. Of course, it could be, but it's not as bad as what I'm going to show you next. This is trabeculated. Please look at how convoluted these muscle strands within the heart are. And although this is the left ventricle, you can see how blood can clot in here. This is also somewhat like the structure of the left atrial muscle.
So let's bring that into clinical focus. If this were the left atrial appendage and these are little blood clots and they form because the left atrial appendage is out of rhythm and just sitting there and you have stagnation of blood, then one of these little black areas breaks off. That could go to the brain, and that's the cause of the stroke, correct?
That is correct. That's absolutely correct. So just wanted to touch upon that. I want to skip. Oops, sorry. I think, and the last thing is that on top of being pectinated on the inside, this word is from architecture and it refers to, related, refers to this, hold on.
Is that the shape of a fort or a castle?
That's the shape of a fort. That's called crenellation. And here you see a left atrial appendage, and look at that. Look how convoluted its anatomy is. And therefore, on the inside, you can certainly understand you could have accumulation of clots or blood if it happens.
Very nice.
I need to erase these. So just to keep that in perspective. And next, I just want to show you here. This is from an old slide atlas. It's an amazing book. But on this side, we have the right atrial appendage, and on this side, we'll have the left. Here's the superior vena cava. And here's the right atrial appendage. And I'm going to draw in this continued line. This will be the opening. This will be the ostium. So you can certainly see that blood can go in and out with ease in spite of having atrial fibrillation. I need to get, I don't know how to get these out one by one, so all of them at the same time. So pardon that. And here you see the left atrial appendage. Please note that it has...
This is the one where the strokes come from.
Yeah. Please note that it's tubular. And from here, it forms all this. So imagine blood trying to get from the atrium into the right or into the left atrial appendage and then being expelled out. Of course, you will have in this region clots.
Yep.
Would you like to comment on that? Because this is, I think, one of the best images showing the difference in the anatomy of both structures.
Yeah, and so people say, well, if I have two appendages, how come you're only going to treat one if I have AFib? Well, a couple reasons. One is the one you've mentioned from an anatomical standpoint. The right atrial appendage is broad-based, and it's easier for blood to get in and out, and it's a little bit smoother. The left atrial appendage has a narrow base, so it's more likely to get a blood clot. But perhaps even more important than that is the fact that if a blood clot leaves the left atrial appendage, goes through the ventricle, then it goes out into the aorta, can go into the brain. If there is a blood clot in the right atrial appendage and it gets out, it would go to the lungs, not the brain on the right. And the lungs have enzymes in them that break up little blood clots all the time. The brain does not. So there are a couple clinical reasons why the left atrial appendage is sometimes called the most lethal appendage. The right is not.
Well, here's an example of another. Atrial appendages are almost like fingerprints. They're so different one from the other. That's why they have to be studied in detail. But here you see another one. They have given them so many names: chicken wings and cauliflowers and what. It doesn't matter. But look at this one that has such a narrow neck here.
Mm-hmm. Yeah.
And here, this is a paper published in 2013 showing the left atrial appendage and its shape. See, compare this one, wide and 3 lobes, like this one, for almost like a finger, like a crooked finger.
Mm-hmm. Yep.
And then we have the ostium. And remember, the word ostium means opening. The openings of these different atrial appendages are so different one from the other. Round, oval. I don't know how to call that one.
Oh, oval with a porch.
And a smiley, I guess.
Yeah.
So they are different, and therefore getting them close. Some of them are wider, some of them are narrower, and of course each one of these types has a name, but I won't bug you with that. Any comment here?
Yes, this brings up the clinical conundrum, and there are no less than 12 different devices that are either clinically available or are in development to close the left atrial appendage. You show one in figure B, which is a device that's put inside the heart. It stays inside the heart. If the opening of the left atrium is perfectly circular, well, maybe that'll work. But as you pointed out, that's not commonly the case. It's usually some other shape. And the problem with these devices is they're not very good at closing the whole appendage, and the appendage is still there and active. And sometimes the appendage is the source of the atrial fibrillation, or at least it's part of the track that the electricity takes. And none of these really stop the appendage from its electrical activity. So that's an issue. What I will show is the AtriClip, which closes the appendage from the outside. If you close it from the outside, it doesn't matter what the shape is on the inside. It closes it 100% of the time, and it also stops the electrical activity of the appendage. And there have been many, many cases where we have done an AFib procedure. The heart is still out of rhythm. We put the AtriClip on to close the appendage, and like snapping your finger, the heart goes back in rhythm. So having the appendage closed from the outside and inactivated, stopping the electrical activity, is of paramount importance. None of these devices do that.
There's another point which is very important. If you look at the surface of this structure, of this device, it's rough. And by itself, it doesn't tend to epithelialize or to recover itself easily. When you put an AtriClip, the endothelium, which is the inner cover on the heart, regenerates completely. And that's another very good point.
Yeah.
So just to, there are some cases where you can have an aberrant left atrial appendage, what is not where it should be, and then others where you could have accessories, but that's something that is discovered when you're doing your study. I don't know that we need to talk about the Coumadin Ridge and all these other structures, but that's what I have for you. Here's something else. Here's a very nice image. This is from a 2016 clinical paper. and shows you how the, let me annotate this, how this atrial appendage needs to be studied, so that when you close it properly at the anatomical ostium and not at what's called the echocardiographic ostium, which is something that would change the shape of the atrium. I know that's one other advantage of that particular clip that you're describing, is that it will sit here on that.
Yeah.
And
Yep.
I think that's could be what I have for you. Let me see.
So if you're listening to us, we're coming from DeBakey Heart and Vascular Center. We're talking about atrial fibrillation. We're talking about strokes. We're discussing preventing strokes by closing the left atrial appendage. It is postulated that 97% of emboli or material that leaves the heart and goes to the brain that can cause a stroke comes from the left atrial appendage. So if the appendage can be closed, it makes sense and logically that you would not have to take a blood thinner. And in fact, I've been closing appendages for 16 years, and we do not put our patients on blood thinners after the appendage is closed. So it's a way to get off blood thinners. For other patients, for one reason or another, they don't want to take a blood thinner. They can't take a blood thinner for atrial fibrillation. We close the left atrial appendage, and again, they don't have to take blood thinners anymore for AFib. Now, is it more effective than a blood thinner? Absolutely. What you don't hear on the commercials when they show people golfing and taking a blood thinner for AFib is that the blood thinners decrease the risk of AFib stroke by 60%. Blood thinners decrease the risk of AFib by 60%. Closing the appendage from the outside with something like an AtriClip decreased the risk of stroke by 97%. And patients no longer have to take a blood thinner. There's a big difference there. Anything else, Dr. Miranda?
No, I guess that's the end of what I had, and just my shameless plug. That's my website in case anyone wants to.
Yeah,
look at it.
www.clinicalanatomy.com. Really interesting stuff on there. What I'd like to do is switch over to clinical now. The remaining time, if you have a question, we can take it. You can go on and text DeBakey, DeBakey, to 37607 if you'd like to ask a question, or a website, go to polev.com. People ask about now the physiology of the left atrial appendage. And it is true, there is a peptide that is released from the left atrial appendage and the right atrial appendage. It's atrial natriuretic peptide, or ANP. But if the left atrial appendage is closed, you still have release of this peptide from the right atrial appendage. And in 16 years of closing appendages, the only thing I've seen clinically is after the appendage is closed, the risk of stroke goes down and the rate of normal sinus rhythm goes up. So we haven't seen anything detrimental on the physiologic side of closing the left atrial appendage. Very interestingly, and this is within the last couple of years, and it's something that we've observed for many years, it's been shown that if the left atrial appendage is closed, the need for blood pressure medications, these are for people who have high blood pressure or hypertension, the need for high blood pressure medicines decreases dramatically. This little peptide, atrial natriuretic peptide, acts on the kidneys and causes sodium excretion, which makes you go to the bathroom more and decreases the amount of water in the vascular space. But what we've seen, and this has been shown to be to happen immediately and last for many, many months is your blood pressure goes down. In fact, what we've gone to now is if we perform a left atrial appendage closure and the patient's on blood pressure medicines, the postoperative orders state that the patient can only get half their blood pressure medicines. And in fact, usually it's even less than that. And we have many, many patients that have been on 2 and 3 blood pressure medicines. After their left atrial appendage is closed, they get off all their blood pressure medicines. So this is a big deal, and it's being looked at in more detail from the physiologic standpoint. But this, in fact, it's even been postulated maybe we should close the left atrial appendage in patients who have refractory high blood pressure. Maybe it would make it easier to take care of their high blood pressure. So that's an added, unexpected advantage of closing the left atrial appendage. You will hear that there's also BNP, which is called brain natriuretic peptide. It's a misnomer. It is not secreted by the brain. It's secreted by the ventricles of the heart. What is the body's idea behind the secretion of these peptides? The idea is if the heart is getting distended, if there's too much volume in the blood over the entire blood system of the patient, the atrium and ventricle can get a bit distended, the wall tension goes up, and these peptides are secreted to tell the kidneys to get rid of some of this volume and get back to normal. That's how it works. But again, closing left atrial appendage does not interfere with that significantly, and in fact has the advantage, unexpected advantage, of lowering the blood pressure. Now let's go to something interesting here. I will try to do a screen share if I can here. Share desktop. And then we'll go to full screen. And this is a clinical case. This is a patient who has atrial fibrillation, and we're on the left side. This is the heart sac, the pericardium. We've opened the heart sac. You can see through the scope. If you take your left or right hand and put it under your armpit on the left side, that's about where we're working through the scope. And if we can get this to play here, we can see the atroclip and we can see the appendage. The appendage is the dark structure inside the pericardium. The heart is beating. We have not given any blood thinners. We have not stopped the heart. And as Dr. Miranda has pointed out, we want to be right across the base of this appendage to close it completely. This clip stays in place, and this will not only isolate the blood from the appendage, but it also electrically isolates the appendage. And there's the clip in place. This procedure takes about 30 minutes. I took care of a 90-year-old lady not too long ago who lives about 3 hours away from Houston, and she went back home 2 days later. So this is, and now her risk of a stroke from AFib has been decreased 97%. She was falling down, elderly lady, could not take blood thinners for AFib. This allows her to be very safe and not take a blood thinner because her appendage is now completely closed. Sometimes the appendage even beats a little bit after it's been removed for a little while. This one has been stapled. This was how I did the first about 1,000 cases, stapled the appendage. But since that time, for the second 1,000, I've used the clip because it's very easy to use and very safe to use. And in my opinion, and I'm biased, of course, but this is the best way to close the appendage. The best way, better than the other 12 that are out there. For some of the reasons we mentioned, with the AtriClip, the appendage is completely closed. There is one other device that can close the appendage completely and decrease the electrical activity, and that's the Lariat device. The Lariat device was also invented by a heart surgeon, by Dr. William Cohn, also from Houston. And Dr. Cohn invented a lariat type device, like a Western lariat that goes around the outside of the appendage and closes the appendage. The company that he started, Central Heart, was sold to AtriCure within the last year, so it's now one of the AtriCure devices. On this slide, you can see some reasons why the appendage is so important in atrial fibrillation. If you close the appendage, you decrease the chance of stroke. If you close the appendage, you can safely stop blood thinners. And thirdly, and not often thought of, but very importantly, if you close the appendage completely from the outside, it no longer has electrical activity, and you decrease this focus of electricity that can contribute to the continuation of atrial fibrillation. So that last one is in fact very important. I'm going to go back, see if we can get out of here, and we will go exit that, and we'll stop the screen share, and we'll go back to us again. If you just joined us, I'm with, this is Dr. Randall Wolf of DeBakey Heart and Vascular Center. I'm joined by Dr. Efrain Miranda, of a clinical anatomist who has many years experience teaching people the anatomy of the appendages, left and right atrial appendage. There are a couple more devices that we should mention that are becoming fairly popular for closure of the left atrial appendage. One is the Watchman device. It's even advertised on television. It's owned by Boston Scientific. It's similar to the device that Dr. Miranda showed, in that it tries to close the appendage from the inside. However, it's a fairly leaky device, and in fact, the risk of stroke is increased right after the placement of the Watchman device. And by FDA rule, patients must stay on a blood thinner for at least 3 months after the Watchman device is placed. The Watchman device also does not decrease the electrical activity of the appendage, so the appendage would still have electrical activity to continue atrial fibrillation. One of the reasons I don't think it's that great, but it's very popular because it can be placed by electrophysiologists. There's a Plato device that's also placed from the inside, an amulet that's placed from the inside, and as I mentioned, the lariat, which is placed from the outside through very small incisions, but it also has to include a left heart cath and crossing from the right atrium to the left atrium. So far what we've talked about the anatomy of the right and left appendage, why it's important, why the left atrial appendage is so important in atrial fibrillation, the different ways to close the left atrial appendage. And keep this in mind, I think this maybe is a way to understand it. If you have atrial fibrillation and you are prescribed a blood thinner, and you're taking a blood thinner every day, you're really taking that blood thinner to stop blood clots from forming in one place. That's the left atrial appendage. So unfortunately, like a lot of medicines, you get systemic effects to the medication. You might notice that you bruise very easily. This is very common with blood thinners. You hit your arm unwittingly against a door jamb, against the edge of the door, you notice that you have a bruise. That's because of the blood thinner. So these are side effects, unwanted side effects, when the only reason you're taking that blood thinner is to decrease the chance of stroke by decreasing clots forming in one place, the left atrial appendage. So it makes sense if you just close the left atrial appendage, you don't have to take the blood thinner, and you dramatically decrease the chances of a blood clot coming from the left atrial appendage. In the case of the AtriClip, which I showed, you're decreasing your chances by 97% because the appendage is then out of the picture. So I think this is an important point. if you are a patient and you're trying to decide what to do for your AFib, you have to ask yourself, do I want to continue to take a blood thinner? Blood thinner decreases my risk of AFib stroke by 60%. Is that good enough for me? Would I rather have a device that closes the appendage so I can stop the blood thinner and decrease my chance of stroke by 97%? But keep in mind, of the 13 different ways to close the appendage, the only two that I'm aware of that safely can close the entire appendage are the AtriClip and the Lariat. And you can look these up. These are both AtriCure devices. They're owned by the same company. The Watchman device, the Amulet, the UltraSeal, they tried to close the orifice of the appendage and have various degrees of success doing that. Efrain, any comments about that?
No, that's really covered everything. This is great. This is great.
Now, the procedure that I perform, the two procedures that I perform at Houston Methodist for patients with atrial fibrillation include one, the entire mini maze, which is making lines of ablation around the heart, closing the appendage, and attacking the little nerves on the outside of the heart. I talked to a patient today, new patient. He's originally from Mexico. He owns two businesses in Mexico, but he lives part-time in the Houston area. He's had atrial fibrillation since he was 16 years old. Now, he wasn't diagnosed originally because by the time they would get him to a doctor, his heart would be back in rhythm. But now he's 46 years old and is on an antiarrhythmic, and he's on Xarelto. So he's taking a blood thinner at 46 years old. Do you really think he wants to stay on a blood thinner for the rest of his life? Probably not. So we're discussing the possibility of doing the procedure that I showed you to completely close the appendage so he can get off blood thinners and probably stop his other medications, probably 93 chances out of 100 of stopping the other medication and 100% chance of stopping the blood thinner by using the mini maze procedure. So the left atrial appendage is closed in a mini maze procedure. In some patients, like the 90-year-old lady I mentioned to you, we really just wanted to close the appendage. Our goal was not to stop her AFib that had been present for 30 years. So in that lady, we just needed to dramatically decrease her risk of stroke or falling down and hitting her head. I've seen one patient who fell down, hit his head, and had to have neurosurgery to stop the bleeding. We closed his appendage because he was on the blood thinner for his AFib. He no longer had to be on it. A few months ago, before COVID started, I saw a patient back in the office who I'd seen 3 years before. 3 years before. And I told him about the mini maze. He had AFib. He decided to stay with medication, which is fine. He came back to my office, and I sat down and I said, after 3 years, why have you come back to the office with your AFib? And he was wearing a hat, and he took off his hat, and he said, you can see where I've had a craniotomy. He fell down, hit his head, bled into his head because he was on a blood thinner for AFib, had to have neurosurgery, evacuate the clot. And he said, Dr. Wolf, I don't want to be on blood thinners anymore, period. So it's not uncommon to see these pretty significant side effects from taking a blood thinner. And being a blood thinner for the rest of your life for AFib, I would suggest to you is often not your best option. So you should think about ways to close the appendage and get off blood thinners. If you want more information, you can go to wolfminimaze.com. That's WOLFMINI, mini, and then maze, like a mouse maze, MAZE, wolfminimaze.com. Or you can call us, get us through Houston Methodist, DeBakey Heart and Vascular, and look for Dr. Wolf. And I'm happy to give you more information on your options to close the left atrial appendage. We do more of these than anybody else in the country, I think in the world. I perform these each week at Houston Methodist in Houston, Texas. So that's our little talk about the left atrial appendage, the importance of it, what we can do to help you stop blood thinners, get off blood thinners for the rest of your life, and decrease your chances of staying in AFib dramatically. I've hoped you enjoyed the program. I'd like to thank Dr. Miranda again for the excellent discussion on where we all really have to start when we talk about disease. Before the pathology, before the surgery, we have to discuss the anatomy. That's the key. So, Efrain, thank you so much for taking your valuable time. Sorry to interrupt your cocktail hour.
Thank you very much. Thanks for the invitation. And yeah, the cocktail's waiting.
And you can again reach us through wolfminimaze.com or DeBakey Heart and Vascular Center. And I'm Dr. Wolf, and I'm with Dr. Miranda. Thank you for joining us this evening. Call us with any suggestions or questions, and have a good evening. Goodbye, everybody.
Bye, everybody.